Thanks so much. Good morning. I have no disclosures. So the goal of this talk is to begin to understand some of the principles of surgery for Crohn's disease, and then to discuss perioperative risk factors associated with surgical intervention for Crohn's disease and how nutrition, biologics, and fertility might impact your decision making. And just a brief overview, Crohn's disease is a chronic inflammatory disease which infects the entire GI tract. For the purpose of this talk, I focused on abdominal Crohn's disease. Incidence is about 5 to 7 per 100,000 people. The vast majority of patients with Crohn's disease will require an operation during the course of their disease, and many will require repeat surgery for disease recurrence. So I think as we know more and more about the pathophysiology of the disease, the biology, and the medications, we may be able to significantly improve this, and also as our decision making improves. I think the key to the decision making for Crohn's disease is it really needs to be a multidisciplinary decision. You need to incorporate the patient, the gastroenterologist, and the surgeon. So these are just what I'm going to review as some points, but they need to be incorporated in a multidisciplinary discussion. And surgery really is complementary to medical therapy. It's really challenging to manage these patients without an IBD gastroenterologist or someone you trust or where you have a relationship in managing the patients. They usually come to us for refractory symptoms. So under the category of perforating disease, acute perforation, and I'm not going to review that, but that requires acute surgery, an intra-abdominal abscess, fistulas, and in the non-perforating disease, stricture with subsequent obstruction or failure to respond to medical therapy. So perforating disease it predominantly presents as an intra-abdominal abscess, and it's usually a patient who's had known Crohn's disease. They present with fever and increased abdominal pain. A CT scan is obtained, and you diagnose an intra-abdominal abscess. The first thing to do is to control that sepsis by draining the abscess percutaneously, usually, if it's possible. And generally, they're possible because they are easily accessible through the skin. Antibiotics, and then during that time period, you want to really optimize the nutrition, because usually in these patients, by the time they present with an abscess, they've been suffering, and they're nutritionally compromised. So consider TPN, and define whatever anatomy you can, if you can define if there's any other areas of disease with either an MR or CT enterography. And then, after you have that acute episode controlled, really the treatment is definitive, is surgery. And if you just drain them and remove the drain, most all the time the abscess will recur. Another type of presentation of perforating disease is fistulas, and these can be between any intra-abdominal organs, small bowel to small bowel to colon, small bowel to bladder are the most common, just based on where the small bowel lies, what organs it's adjacent to. Diagnosis is by CT scan, but many times you might not see or know about that fistula, especially if it's an entero or iliosigmoid, before you operate on the patient. And again, surgery is a definitive treatment. It's usually, there's one primary area of bowel involved, and the other is an innocent bystander. And a basic principle of all this surgery is to really try to conserve as much bowel as possible, so you want to minimize your operation on the innocent bystander. And under the category of non-perforating disease, predominantly this is strictures, so an inflammatory area of the bowel that then becomes fibrotic with time. Ileocolic stricture is the most common, but then they can also be seen together with other small bowel strictures or small bowel strictures alone. Evaluation is with an MR or CT enterography. And the treatment, one option is, especially for an ileocolic stricture, a lot of times the gastroenterologists have already tried to dilate it if it's a short stricture by the time we see them. And if that fails, surgery. This is just a picture showing an endoscopic dilation of an ileocolic stricture. And many of the times they'll have immediate success, so we won't hear from them. But then frequently the stricture recurs, and usually if it's refractory, they end up with surgery. Strictures, surgical management is a balance between strictureplasty and resection. The overall goal, as I said, is to really minimize bowel resection. Stricturoplasty is safe in a non-inflamed bowel, but in a very edematous and inflamed bowel, it's better to resect. And really, stricturoplasty being done with minimal morbidity and mortality, and it has actually a very low rate of recurrence at that site. So then just to touch on the perioperative considerations, I'm going to start with nutrition. And when you look at risk factors for morbidity after surgery for Crohn's disease, when you start to look at NSQIP and as some of the national databases, a lot of the same factors come out. And really it's preoperative sepsis or preoperative infection, because most of the post-operative infections in these patients, most of the post-operative morbidity is related to infection, so clearly preoperative infection is a major risk factor. Malnutrition, preoperative intestinal obstruction, and perhaps use of TNF inhibitors. And as I said, wound infection and anastomotic leak, small bowel obstruction, DVT are really the leading complications in these patients. In Crohn's patients, malnutrition is common and much more common than in patients undergoing other general surgery procedures. About 7% of these patients will have evidence of malnutrition by lab values or diagnosis or weight loss, compared to 1.8% in the general surgery population. We know that unmanaged malnutrition increases your mortality, increases your length of stay, increases your readmission and the total charges for that procedure. And perioperative TPN is commonly used in these patients to try to optimize nutrition beforehand, and it is effective. It's also effective in really calming down that intestinal inflammation and allowing you to minimize the amount of bowel you need to resect at the time of surgery. So a lot of this Crohn's surgery should be planned and elective, so you really focus on optimizing your patient beforehand. And I think it's been very controversial about the role of biologics and their role in perioperative morbidity. When they first came out, really it was felt that they were potentially impacting surgical outcomes. But I think as we've gotten to know more about them and understood more about their half-life and how to use them, it's not quite as clear that they're playing a role in our surgical morbidity. But again, this is a multidisciplinary discussion with the gastroenterologist who's helping you manage the patient, because you really want to balance the use of these biologics to minimize surgical complications and maximize the disease until recurrence. So you're not going to do anyone a benefit by holding these biologics for a long period of time before surgery and allowing the disease to become worse. So it really is a discussion. Of the treatments for Crohn's disease, the TNF inhibitors are really the most aggressive treatment, but they're really commonplace in most patients that you see who come to surgery. Most everyone is on a biologic at this point. So do we really have the information to implicate these TNF inhibitors in our perioperative morbidity? And there have been a series of studies starting in 2004 the first set of series suggested that there was an implication, but really no one's shown statistically significant in Crohn's disease. I tried to separate out the data from Crohn's disease and ulcerative colitis. And really in Crohn's disease, when I looked at it, it's really inconclusive. So in 2004, 313 patients who had received Remicade between 1998 and 2002, and 6 patients had an infectious complication in the Remicade group versus 1 in the control group. Really, the numbers are too small to make any conclusion. Another study, 270 patients received it again between 1998 and 2001, and they couldn't find any association. Then from the Cleveland Clinic, 60 patients with Remicade within 3 months versus patients who had never seen Remicade, and they found an increased risk of 30-day readmission, sepsis, and intra-abdominal abscess associated with Remicade. But all these studies, there's subtleties in how they selected the patients who were on Remicade, what window they included. So some of them included patients who had Remicade more than 3 months prior to surgery versus others used a smaller window. So I think the literature is quite hard to interpret, and probably there's insufficient information to conclude that this is associated with perioperative morbidity. And I just wanted to add that I think We think a lot about the role of TNF inhibitors in surgical morbidity, but then we also need to think about their role after surgery. And we need to be really proactive about getting these patients back to their medical doctors to get them on post-operative prophylaxis and work collaboratively to manage these patients. So although this wasn't included in the topic, I think it's really an important point to drill home, and we've started to look at our own practice at Hopkins to see how good we are at working collaboratively and to take care of these patients after surgery. So we know that patients with Crohn's disease, a lot of who we operate on, many will have recurrent disease. And now, with the more rigorous studies, 30% of patients will have endoscopic evidence of recurrent disease at 3 months. So this is now emerging as the window to really get the patients back on a biologic to prevent that next operation. And by 6 months, 70 to 90% will have evidence of recurrent disease. So now the recommendation is to make sure they get that repeat endoscopy between 6 and 12 months to reevaluate their disease and decide what post-operative regimen they need to be on. And there's different stratifications of post-operative regimens. Immunomodulators such as azathioprine have been shown to be effective to prevent recurrence. As azathioprine versus placebo decreased recurrence from 77% to 50%. Versus mesalamine, there was no difference, but a meta-analysis suggested that purine analogs are more effective for preventing that recurrence. So it is an option in a patient who has a low risk of recurrence. But you see now a lot of patients are being put on a TNF inhibitor. I think we tend to see a more complex patient population, and so there's a great concern that they're going to have aggressive recurrence. So a lot of patients are being put on Remicade or another TNF inhibitor for post-op, and it's really based on this one study from the University of Pittsburgh where 24 patients after ileocolic resection for Crohn's disease were randomized to either receive post-operative Remicade or placebo, and there was a lower rate of endoscopic recurrence, significantly lower, 9% versus 85% in the group that didn't receive Remicade. So now there's a sort of a general flow of how these patients should be managed after surgery to decrease their rate of recurrence, and it involves risk stratification. And essential to that risk stratification is working collaboratively with the gastroenterologist and getting them to that colonoscopy at 6 to 12 months. And then based on their risk stratification, they'd either get no medication, an immunomodulator, or TNF inhibitor. And I think, we see the patients within a few weeks after surgery, so we can really influence the rate of revisiting their gastroenterologist and staying on this algorithm to try to prevent recurrence. We looked at our efficacy in getting the patients back to their gastroenterologist after surgery, and we found that we see all our patients after surgery, 93% come back to see the surgeon, but only 50% within a month see their gastroenterologist. And then within a year, we found that 95% of patients had seen their gastroenterologist, but we really didn't get them back as early as we wanted to. And by 6 months, 3/4 had gotten a colonoscopy. By 12 months, we really hadn't increased anymore. So we still have room to improve and really working collaboratively to ensure the best care after surgery. Finally, I'm going to touch on fertility and how we can play a role in managing or optimizing fertility in these patients. So as you go back and look at the studies, it really is emerging that the infertility rate, if you look at a population-based level, in Crohn's patients is similar to the general population. And what they found is that there's greater voluntary infertility in Crohn's patients. So in a case control study, there's a decrease in the mean number of children in Crohn's disease patients versus healthy patients, but it's voluntary. IBD does not affect male fertility, though some of the medications do. And certainly it makes sense that surgical complications may impair fertility, but I think most of these studies are on the smaller side, and it's hard to fully interpret that. IBD can impact your pregnancy outcomes, and quiescent IBD during pregnancy, you have the same outcomes as the general population, but if you have active disease, particularly at the time of conception, it will impact your pregnancy outcomes. And it will increase your risk of a premature birth, low birth weight, and premature delivery. Pregnancy itself won't impact flares, but really the key to success is disease control at conception. So for some patients who have very aggressive disease, this may mean surgery before considering pregnancy to improve pregnancy-related outcomes. And this is just showing that, just reiterating that that pregnancy does not cause, really is not associated with increased number of relapses during surgery. And essentially, if you were going to have bad disease, you're going to continue to have bad disease. If you had really your disease under control, you're going to continue to have that. So it's not exacerbating the course of the disease. And really, active disease at the time of conception appears to be the greatest risk factor for pregnancy-related outcomes. And again, this is where you want to work collaboratively with a gastroenterologist with patients who are considering becoming pregnant to really optimize their outcomes. So in conclusion, I think the management of Crohn's is complex and really requires a multidisciplinary approach. And all these outcomes can be improved as we work together and communicate. And work together to combine medical therapy, nutritional therapy, and surgical therapy. And we can minimize our perioperative morbidity, maximize our time until disease recurrence, and improve the patient's quality of life. And effective disease control will likely facilitate fertility. Thanks.